Thank you, chairpersons, and thank you, Professor Ranjan. It's an honor to be here. It's always a tall order to follow Professor Call, and I don't know, for some reason, we are the pair to always go in a pro and con session. I don't know why that happens. So bear me out, because a lot of it would be repetition. And I just want to quote a bit of one of the pioneers of public health foundation of this country, Professor K.S. Reddy. Quote, "How do you teach the same subject to undergraduate, an MD, and a postgraduate, a DM?" So he says that I would teach facts to the MBBS, concepts to the MD, and controversies to my DM students. So that's what I'm going to do. I'll start with controversies and probably factor in some facts and concepts as they emerge. And again, as I said, this will be more of a discussion because you've already had a total update of this entire thing about PFO from Professor Call, so I'm not going to repeat that. So the device closure of PFO came in, I guess, somewhere in 1990s, and ever since the inception, it's run into a controversy. It's been debated hotly. So if you, again, the various options that you have for a secondary prevention of an ischemic event in a stroke which is attributable, again, that's, I guess, the word is being attributed to PFO would be, yes, these are the options that you have with all the evidence that you have in the universe. Is a PFO closure with antiplatelet, or you just have antiplatelet, or you have an anticoagulant therapy alone, which we haven't discussed till now. So let's start off with, I would completely agree with Professor Call, in fact, in a lot of things. In fact, he's done my work much simpler, because the title says, is PFO closure the standard treatment for, for prevention of stroke in patients with ESUS? That's it. It doesn't deliberate on the specifics. And he's already done that. He's already specified. So I'm actually going to reiterate the same thing, because I'm against that universal one-glove-fit-all approach to anyone whose stroke is attributed to PFO in a patient who's so-called ESUS, and you close with a device. That I'm debating against. And I think he's already, in fact, debated for me in his talk. You would agree with me on that, Professor Call. So let's start with the first controversy of linking a stroke with a PFO. So it's tough because, again, having a PFO is not sine qua non. We've already heard about that. The other thing is, unless you actually demonstrate the clot in its act, you need to catch it in its act. That is, you need to see the clot wriggling out of the atrial septal aneurysm or atrial septum, and then going on and lodging itself somewhere in the artery and then causing a stroke. Probably, that's the only definitive way of saying that. And this whole concept of ESUS has also run into a bit of a controversy now, thanks to the 2 negative trials of Navigate ESUS and Respect ESUS, where, because this clinical construct that in so-called cryptogenic stroke, you have the subgroup of strokes wherein it is embolic. Why? Because they don't have such a thing. You don't have an artery, you don't have a valve, you don't have what is demonstrable atrial fibrillation, and you have an embolic kind of a phenomena on the MRI. They are non-lacunar and cortical. Therefore, there must be an embolus. It's coming from somewhere. Therefore, you say it's ESUS. And that is the whole basis for using the NOACs in these trials, and for some reason, the Navigate ESUS and Respect ESUS were negative. It didn't negate anticoagulation, but then certainly the NOAC versus antiplatelet was negative. So again, we are back to that thing of antiplatelets being supreme in some way. So this thing again has become controversial. And the cryptogenic stroke definition is also controversial. And you would agree with me, Shailja would agree with me on that, clearly when you say cryptogenic is where you don't have a real reason why a person is having a stroke. Now, I fail to understand why there should be such a big problem in a 70-year-old who's a diabetic and hypertensive, has a large artery stenosis and also has an AF, but that guy has, because he has both, he's undetermined. So you have a problem in our classification system of what is cryptogenic also. So you have, according to Toast, you have cryptogenic or undetermined source, which have all these, subgroups. in one big bag. So that itself becomes a controversial thing. So when you are trying to link a stroke with a PFO, you probably should need the presence of some kind of a venous thrombosis for the clot to progress and cause a paradoxical embolization there. And yes, the ROPPE score. So we're not getting into the ROPPE score, we've already dealt with it. So the higher the ROPPE score, the higher the, the linking that, yes, maybe that's the reason it's caused a stroke. And we've heard that in this subgroup of so-called not known why cause of strokes, the presence of PFO is much higher. Now, there are people who have all these problems and you can't give a device closure. You must understand that there's a subgroup where there is an anatomical variation or there is something else which is provoking a venous thromboembolism. You need anticoagulation on board. In fact, one of the arguments is, look, the reason is that there is a clot somewhere and that is finding a path because there is an opening. So please prevent the clots from forming. You need an anticoagulation. Why are you actually trying to occlude something else? So when there is a clear-cut reason where you need an anticoagulation on board, have these studies actually pitted them against only anticoagulation? Unfortunately not, including all the recent trials. So maybe there are the specifics about an anatomical problem with the shunt itself. You have these large shunts, you do have a demonstrable, you have a lot of biomarkers there which say that yes, the emboluses are going, whether you're using TEE or using the bubble test with the TCD, what have you. But then, coming back to the same thing, that even the RESPECT trial or whether you have the recent trials, what percentage of these patients were actually put only on anticoagulation? Just 15%. So this is one subgroup wherein you haven't tested the device with antiplatelets as against only anticoagulation. All right? So, and then these adverse events, they were enumerated. Well, you can't wish them away. And I would certainly agree with this, that when you're going for intervention, you need a track record and a logbook which says that this guy is good. I would certainly go to only him. Otherwise, this whole list of adverse reactions can happen. So this again, all these trials, these 6 trials probably are the ones which have been looked into again and again and again and again, and I'm not going to get into it. The summary clearly shows that there is an evidence for a device closure with antiplatelets as against only antiplatelet. Is it only against anticoagulant? No. So, and this has again been seen that if you have a composite outcome, it clearly is favoring a device closure. So also the recurrence of an ischemic event, not very minor events, not all-cause death, and atrial fibrillation clearly there with the device closure as against the, the medical arm, whether it is any study that you have undertaken, whether past or present. Recently in the European Heart Journal 2018, Ahmed et al. Had a meta-analysis. So it was a nice meta-analysis because there was very interesting summary points that, look at this, the recurrence of an ischemic event is low, okay? That you will all agree with me. It's not like having a risk after, say, a large artery stenosis. So there you have a huge risk, and if you have a TIA and you have an ABCD, the score which is high, you're looking at 16% at the end of a week. That kind of a risk you have. And here you have an annual risk of 1.16%. And certainly this very minutesimal risk is definitely reduced 2/3 if you have a device closure as against a medical therapy. Again, the medical therapy is antiplatelets. And the benefits from PFO closure depends on shunt size. That's a no-brainer. Yes, accepted. So large shunts would benefit from a device closure. And the presence of this movement of the atrial septum, whether it is more than 10 millimeters, is not exactly an aneurysm. It is actually an increased mobility that you call it as an atrial septal aneurysm. Presence or absence has run into a little bit of a rough water. Some do believe that probably doesn't really add on to the risk. But atrial fibrillation is there to stay. Unfortunately, current evidence does say that this causes atrial fibrillation. Now, ladies and gentlemen, when you have a stroke and you have an atrial fibrillation documented and you're looking for, a 1 year into loop recorders, and bang, you have an AF here, which is paroxysm. So, current evidence Are you going to ignore that? Aren't you going to put these patients on anticoagulation? In which case, I have a patient with a device which is closed. So they are on short term or a long term or whatever you decide on antiplatelet, and plus I'm going to get an anticoagulant on board. Can I ignore a paroxysm of an AF, even if it is a short epoch? There's still ongoing studies where they're trying to look into what is the significance of having little epochs versus actually more runs of atrial fibrillation. That we're still trying to get evidence of it. But at this point of time, even a paroxysmal AF carries the same risk for a recurrence of stroke. And the magnitude of benefit, it's okay. Now, there are studies which said individually you have the NNTs in terms of double figures of 28 and 29, and that's in a longer duration of time, probably even less. But overall, when you're looking at a large shunt, yes, it is 96. But if you take all PFOs, and people have actually closed all kinds of PFOs, then the number needed to treat is 178. So then there was a deluge of comments which came in after the 2017 publications of the FRESH trials. And they said that the trials are open label, they were blinded adjudication of endpoints, and they didn't use a sham procedure. Sham procedure is an extremely popular term. For any intervention, you always need one sham procedure. I don't know whether I confirm to this, but this was one of the comments which has been raised as limiting the, understanding the results. And the underlying mechanism of stroke in patients with PFO is presumably paradoxical, embolism from somewhere. And shouldn't you really be treating why? The cause of embolism, and treat it by anticoagulation. You have a thrombophilic state, you have a cancer there, or you have something else which is there, and shouldn't you be treating that instead of going and closing holes? So the same editorial of Alan ROPPER, Dr. Cole, we think alike. You see, we picked up the same literature. So in fact, he said the same thing. And certainly, he really talked in favor of tipping that, the point was in tipping in favor of the device closure. But I liked what he said. He says, following the trail of the travail of trial names. It's almost like a conundrum, which is, the number of trials. There are 3 trials, and NEJM will say no, 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 and then the 3 trials, bang, they come say yes, yes, yes. It's like a mechanical thrombectomy. After that, 2013, there are 3 said, don't even go near mechanical thrombectomy. In 2015, you have 6 trials which said, and there's no clinical equipoise anymore. So probably we're going there, but then yes, at this current point of time, I don't think you can just generalize and say that statement of the debate. I don't know why Professor Ranjan chose that particular title. That title is debatable, but then certainly there are subgroups where you can use the device closure. So quickly, the current guidance for closure of PFO, patients with PFO and cryptogenic stroke. We have the American Academy 2017, and you have the NICE 2013, you have the Cardiology 2016. Even there, they certainly said in selected patients you should. And then, of course, we have the updated guidelines that Professor Call has put up of the Canadian and the other guidelines, which have clearly, again, reiterated the same point. You can't generalize, but you can certainly select out patients who would need that, and you can go ahead. And then, so what you need to know is, they don't apply to old guys. So it will be 60 years and less. And for patients who are open to all options, we make a weak recommendation that PFO plus antiplatelet rather than anticoagulant, and we'll come to that why. And in patients, anticoagulation is contraindicated or declined, we make a strong recommendation for the device closure with antiplatelet. And in whom closure is contraindicated or declined, we make a weak recommendation for anticoagulant. And further research will alter these recommendations which involve the anticoagulant therapy. Remember, it's just 25% all told in all these arms who were actually pitted against only anticoagulation. The great summary is probably the best possible evidence you have in all the international guidelines, because you just don't recommend. You also give why and why not, and along with references. So selection of a treatment strategy should be patient-centric, patient-specific, informed by clinical trial evidence and tailored to presentation, findings, preferences of each individual. So you actually, in this, you have the patient preferences who have been factored in. So if you have a PFO closure followed by antiplatelet therapy versus only antiplatelet therapy. That's the first thing. It probably has a large decrease in the ischemic stroke, all right? That is 8.7% absolute risk reduction over 5 years, and has a risk of device or procedure-related adverse events of 3.6% in 1 year, has an increase in persistent AF of flutter of 1.2% per year at 1 year, and no difference whatsoever, no difference, ladies and gentlemen, in death, major bleeding, pulmonary embolism, TIA, systemic embolism in 5 years. Now, if you have a PFO closure followed by antiplatelet therapy compared with anticoagulation, and that's the arm I'm touching upon, may result in little or no difference in ischemic stroke reduction. They're equal. Probably decreases major bleeding. Definitely, anticoagulant has more risk of a bleed. Has a risk of device or procedure-related adverse events 3.6%. That's with device. Probably has an increase in persistent AF flutter with device closure as against anticoagulation. Again, no difference, death, pulmonary embolism, TIA, or systemic embolism. Okay? So when this was given to the patients and you wanted patients' information, that's a very aware society we are talking about. There they said, PFO closure followed by antiplatelet versus antiplatelet. They said patients for whom anticoagulation is unacceptable, contraindicated, then they should go for device closure. Now, device closure followed by antiplatelet versus anticoagulation, that was a real eye-opener. Here, the patient said, even if there's a risk of a bleed with anticoagulation, 7 times, even so, we would prefer anticoagulation versus having a risk of stroke or having a device closure. This was amazing. So then they actually went into the patient's thing and asked patients, what do you want? I mean, because there's a risk of a bleed with anticoagulation, and I'm giving you device closure with an antiplatelet, even the preferences actually were tilting towards anticoagulation. So with anticoagulation versus antiplatelet, probably, because when there are some who say, look, it's not going to actually give a major difference as far as a major stroke is concerned, or a death is concerned, or major embolic phenomena is concerned, I'll take antiplatelets. Why do I get into the bleeding risk? So these do remain still controversial issue. So uncertainties to be addressed in future research is a relative merit of a PFO closure versus anticoagulation alone. That hasn't really been tested. And further trials of PFO closures, antiplatelet agents in small PFOs, we don't know. And the most important thing is a longer trial to address longevity. We have one, RESPECT, which went on and which showed that these things can persist and really not break off or embolize or do something else. But then we need more evidence on that. So the key questions, this is my last slide, are what are the benefits and harms of PFO closure versus anticoagulants, including NOACs, in patients with PFO and cryptogenic stroke. And now, since this whole concept of so-called cryptogenic versus ESUS, everything is now again come out into the open as gray zones. What was be assumed as getting more clarity has become more gray. So probably you can't club a 70-year-old who has a carotid artery stenosis and an atrial fibrillation, put in stroke of undetermined origin. It's the same as a 28-year-old who's a non-diabetic, non-hypertensive, has no reason why he has to have any event whatsoever and lands up with a stroke. So they are different ball games. So here you will have a whole lot happening, whereas this probably is the area wherein these issues would gain more clarity, and maybe in such selected patients you would be given the choice of a device closure of PFO. So what patient groups are more likely to benefit from PFO versus medical? Explore whether effect of PFO closure versus medical varies with shunt size, presence of ASA and age, and which device of PFO closure is the best, and what's the longevity of this device and monitoring of device performance. I'm sure any of these answers would certainly give you at least a publication in NEJM or Lancet. Thank you.